Dr. Shopin, start.
Dear colleagues from across the South Asian region and beyond, it is my great pleasure to welcome you to this first webinar organized by South Asian Association for the Study of the Liver on fatty liver. We have galaxy of eminent hepatologists from the South Asian region in the faculty today who will be highlighting us, enlightening us on different aspects of fatty liver. We also have a very enlightened chairperson who is the president of SASL and also a very eminent hepatologist as the co-moderator of this session. I'm sure you'll be greatly benefited from today's deliberations. For information, this webinar is being telecast live in Facebook by Raj TV, an online television channel in Bangladesh, and also on the official Facebook page of South Asian Association for the Study of the Liver. Lectures will be there, and you can visit these Facebook pages later on to review the lectures if you want. So without delaying any further, it is now my pleasure to invite Professor King Mang Win from Myanmar to introduce the speakers, invite them, and carry us through the session. Professor King Mang Win, please.
Thank you very much for introducing my co-moderator, Professor Mamu. And thank you also, Chairperson Professor S.P. Singh, for inviting us to participate in this webinar as co-moderator. We have chosen this fatty liver or non-alcoholic fatty liver disease, or NASH, as becoming one of the emerging diseases, not only in the world, in Southeast Asia as well. We have the Asia in general, as we eat a lot of rice. So we eat a lot of cooking oil. And then we are left with the old habits, as well as we have a new KFC, many very high calorie loaded foods stuffs are coming in like in my country very well. So this is a very important subject. And we have chosen the very important topics like a pathogenesis, non-invasive assessment, and holistic approach to intervention, and also pharmacotherapy. So the first speaker is our very famous speaker from Pakistan, Professor Wasim Jafri. Professor Jafri is Professor of Medicine at Aga Khan University and the Director of the WGO Training Center in Karachi, Pakistan as well. Professor Jafri will enlighten us with this presentation on the pathogenesis of fatty liver. Professor Jafri, please.
Dr. Wasim Jafri, please unmute yourself.
Yes, thank you very much indeed for inviting me to be speaking on something which is extremely, extremely important globally, not only for our part of the world, but NAFLD has really taken over like a non-infectious pandemic globally. And I'm going to highlight really the pathogenesis of it, which is still, you know, something which is evolving. It's not something that is 100% clear, but at the same time, it is something which I need to emphasize so that at least our younger colleagues who are doing their PhDs and whatnot, they can take over from where we are right now and hopefully address all those issues which needs to be addressed in time before it's too late, because the disease is indeed taking over like nothing else, you know, from when again, it has no boundaries. It affects everyone, the richest, the poorest, and all the countries that we all belong to. Let me share can you all see my slides now?
No, we can't see your slide.
You can't? Oh dear, I'm trying to share it. So what's happening? Share slides. Yes, should be okay now. Is it okay?
Yeah, we can see the slide.
Okay, we can see now.
All right, so sorry about that. So let's start the proceedings. Non-alcoholic fatty liver disease, NAFLD, as we call it, pathogenesis. I have no disclosures related to this talk. Let me start with some introduction and at the same time take you along the part that I'm going to discuss in the initial introduction would be highlighted, in fact, in more graphical way a little later. Non-alcoholic fatty liver disease, we all know, is a heterogeneous group of liver diseases characterized by accumulation of fat in the liver. The heterogeneity of NAFLD is reflected in a clinical and histological spectrum where some patients develop isolated steatosis of the liver and that's it, termed as non-alcoholic fatty liver, whereas others develop hepatocyte injury, ballooning, inflammation, and consequent fibrosis, termed non-alcoholic steatohepatitis NASH. Systemic insulin resistance is a major driver of hepatic steatosis in NAFLD. Lipotoxicity of accumulated lipids along with activation of the innate immune system are major drivers of NASH. Lipid-induced sublethal and lethal stress culminates in the activation of inflammatory processes such as the release of pro-inflammatory cytokines and cell death. Innate and adaptive immune mechanisms involving macrophages, dendritic cells, and lymphocytes are central drivers of inflammation that recognize damage and pathogen-associated molecular patterns and contribute to the progression of the inflammatory cascade, which results in all what we are going to discuss. While the activation of the innate immune system and the recruitment of pro-inflammatory monocytes into the liver in NASH are well known, the exact signals that lead to this remain less well defined. Further, the contributions of other immune cell types such as neutrophils and B cells is an area of current intense research. Dear colleagues, many host factors such as the microbiome and gut-liver axis modify individual susceptibility to NASH. There is a cohort of people who would just have the fatty liver and nothing really progresses for years and years. And amongst our patients, there are those who progress to NASH and then going on to develop cirrhosis and other complications. So hence, it's not just the environment. I'm very, very confident that genetic factors also play a very significant role. So here we have simple steatosis. Hepatic steatosis, as we can clearly see, no inflammation, can be diagnosed with imaging alone. And that's what the ultrasounds certainly, the pictures that come in with the report really tell us that this is the altered echogenicity, which means that there is excessive or more fat in the liver than there ought to be. So there is low risk of disease progression at this stage. But what takes it further? Here we have the NASH, where we have not only just hepatic steatosis, we have active hepatocyte inflammation in the form of ballooning degeneration. You can clearly see that. Risk of fibrosis and progression to cirrhosis, and all the sequelae of cirrhosis, which also includes HCC. Requires a liver biopsy, however, for precise diagnosis. So how does NAFLD occur? We aren't exactly sure. There are lots of hypotheses, there are lots of animal models, etc., and lots of, in fact, information is available, but to name really the exact nature, how it happens, still needs to be worked out, and lots of work is currently happening. So lots of lab work has been done on animal models and on human liver biopsies. There is a two-hit hypothesis, and I'm sure everybody likes that because it is rather easy to remember. What happens is that there is a sedentary lifestyle, there is a high-fat diet. Always we talk about insulin resistance, and of course, obesity. So that's the first hit. We talk to our patients on these things almost routinely. The second thing, which is more scientific and academic, is the oxidative stress, the mitochondrial dysfunction, inflammatory cytokines that play their role, gut dysbiosis, and of course, all the endotoxins that pass through the gut, through the bacteria that we harbor in our intestine. And certainly the small intestinal bacterial overgrowth is also supposed to play a role in that. So it is normal liver going on to NAFLD, the simple steatosis, followed by NASH, and then cirrhosis. This is more complex, the multi-hit hypothesis. Multiple insults include acting together on genetically predisposed patients. So there is a genetic predisposition. Insulin resistance, altered gut bacteria, the inflammatory cytokines. It is not necessarily a linear progression from simple steatosis to NASH. Currently, most accepted understanding of NAFLD is the multi-hit hypothesis. And here come the pictorial graphics of what I'm going to illustrate on. So let's start first with the insulin resistance. And hence, there is so much of resurgence of free fatty acid as a result of that, producing mitochondrial dysfunction. And this mitochondrial dysfunction or paroxysmal functional cannot handle the increased lipid influx, respiratory oxidation may collapse, and impairment of fat hemostasis, generation of lipid-derived toxic metabolites, and overproduction of ROS. Of course, that is so harmful for not just, but all the other conditions that we are more familiar with from inflammatory process. So here is the ROS, which is increased and hence produces total mitochondrial disarray. And then we come to the ER stress, the endoplasmic reticulum stress, and let's talk about it. An increased protein synthetic input, a primary dysfunction of the ER or lack of ATP can lead to unfolded protein accumulation within the endoplasmic reticulum, activating the so-called unfolded protein response, UPR. In NAFLD, factors that induce UPR include hyperglycemia, mitochondrial injury that depletes ATP, hypercholesterolemia. UPR leads to the activation of C-Jun terminal kinase, which is abbreviated as JNK, which is an activator of inflammation and apoptosis. Its silencing in animal models at least leads to decreased steatosis and steatohepatitis. So phosphatidylcholine and oxidative stress. What about the adipose tissue dysfunction, which is the hallmark? In fact, you can see the IL-6, the TNF-alpha, and the leptin. What are their role in the pathogenesis? Adipose tissue contributes to the maintenance of low-grade inflammatory states by producing pro-inflammatory cytokines. Serum levels of IL-6 and adipocytes expression of TNF-alpha are increased in obese patients and subsequently decline following weight loss. So hence, that's the evidence. However, leptin increases in obese subjects as a consequence of leptin resistance, and its pro-fibrogenic role has been demonstrated in various in vitro and animal models. Leptin activates hepatic stellate cells through the hedgehog and mTOR pathways. It was suggested that Kupffer cells are targeted with leptin and are stimulated to produce TGF-beta-1 and subsequently activate hepatic stellate cells. The story doesn't end there unless I discuss about the dysbiosis, the gut role, and that is very important in this pathogenesis. So what is dysbiosis doing for fatty liver? The lipopolysaccharide is one of the main toxic bacterial products, and it may act linked to co-receptor CD14 as ligand for TLR and consequent activation of the inflammatory cascade, including stress-activated protein kinases, JNK, P38, interferon regulatory factor 3, and nuclear factor JB. Patients with NAFLD have significantly increased gut permeability and a higher prevalence of small intestine bacterial overgrowth compared to healthy controls. And then comes the final cascade, the inflammatory state. I've already emphasized quite a bit of that, and let's see what it is doing with the NKB and JNK. The two main inflammatory pathways, the JNK-ANAB1 and IKK-NFKB, are critically involved in the development of the chronic inflammatory state in NAFLD. JNK is a member of mitogen-activated protein kinases associated with the activation of apoptosis and development of NASH. So remember that JNK is a member which has got a lot of role to play in the inflammatory process of NASH. Nuclear factor JB kinase B, NFKB, is a transcription factor and a primary regulator of inflammatory activation. And its IKK2 subunit is the major component required for its activation during the acute inflammatory response. Persistent NFKB pathway activation has been shown in animal models of NAFLD as well as in patients with this disease. So this table clearly tells you the role of cell type, the activator or the recruiting factor, and their role in NASH. So it's a summary of Kupffer cells with the activator as NLRP3, inflammasome, TLRs, and interferon genes promote NASH in early phase, produce increased TNF-alpha and CCL2. Bone marrow-derived monocytes, the activator is CCL2, CCR2 axis. It promotes inflammation and fibrosis in NASH. What about the dendritic cells? We are so familiar with fibrosis and all that. It's unclear. However, increased intracellular lipid and pro-inflammatory phenotype. The neutrophils and what is their role? Promote NASH through microbial secretion and the NETs. Th1 and Th17 cells promote NASH through increased production of interferon gamma and IL-17. Th2 cells decrease production of anti-inflammatory cytokines IL-4, IL-5, and IL-13. Cytotoxic T cells, the activator is interferon 1, type 1 interferons. It promotes NASH and HCC, produce increased amounts of interferon gamma and TNF-alpha. The B cells, it's unclear though, but promotes fibrosis in mouse models of hepatic injury. So that table really summarizes all these cells which play a definitive role. Some is yet to be defined clearly, but I think from the animal models, we have some know-how about their pathogenesis. So here we have a normal liver and it progresses to NASH. How fast does that happen? Studies using paired biopsies estimated an increase in fibrosis stage by 7 years. NAFLD was estimated to increase by 1 fibrosis stage every 14 years. It is completely variable. It doesn't mean that this is absolute. It differs on so many environmental and other factors which are out of control. What about the genetic factors such as the atatin-like, phospholipase domain containing protein 3 and abbreviated as PNPLA3. The membrane protein expressed both in the liver and in adipose tissue. Participates in breakdown of intracellular fat, influenced by carbohydrate and lipid intake. Those with PNPLA3 genotype MM have an increased tendency for hepatic fat storage. Ethnicity plays a definitive role. Study from US and European looking into it. The Europeans have homozygote prevalence of 5%, African Americans 2%, the Hispanics 25%. And on the left side, you can see the hepatic TG content, the triglyceride content, and of course it goes as we go with the MM genotype. So here we have a normal liver going on to steatosis, steatohepatitis, and fibrosis going on to cirrhosis. The relative magnitude of genetic contribution to disease severity and progression is clearly outlined here, that with the PNPLA3 genotype MM, as you can see, the arrow gets stronger and darker. And in fact, with the increased BMI, it has got a definitive role to play in the pathogenesis of this disease. So dear colleagues, to conclude what I have said, of course, it's the multifactorial pathogenesis of NASH, both hepatocyte lipotoxicity and immune-mediated inflammation play key roles. No two thoughts about it. Activation of hepatic stellate cell occurs as a consequence of signaling from stressed or apoptotic hepatocytes and macrophages, although other immune cells may play a role as well. So this triadic lesion forms the cornerstone of progressive NASH. The hepatic stellate cells, the apoptotic, and the macrophages resulting in all this thing. Our nascent understanding of this heterogeneity would also suggest that combination therapy, although logical, may uncover potentially redundant pathways in NASH pathogenesis, as we are going to hear in further talks. Regardless, mechanistic studies that answer fundamental questions in NASH pathogenesis are still needed. As I started my talk, that more and more research is needed to answer these questions. These include what? Exploration of mechanistic questions that address early events in liver injury in NASH, such as the consequences of sublethal hepatocyte injury. Another key area is the definition of the triggers, kinetics, and magnitude of immune cell activation responses along the NAFLD spectrum, and to define the individual and synergistic contribution of each type of immune cells. So here I end my talk with this last slide. I've already emphasized it. So thank you so much for listening to my presentation. Thank you.
Thank you very much, Professor Jeffrey. You have shown us beautiful cartoons and clearly demonstrates the molecular mechanisms of the pathogenesis of the NAFLD. There is one question from an audience. What is the role of increased fructose level in the development of the NAFLD?
What is the role of increased?
Fructose. Increased fructose.
Yes, it is. It has got a definite role. And of course, it has been emphasized, as one of the factors that contributes towards the hepatic lipid deposits and the triglyceride accumulation. We can't deny that. So the higher the fructose content, it has been researched and it has been seen in animal models too, in mice especially, that it has got a role in the pathogenesis of NAFLD and NASH. Start with NAFLD, and then, of course, NASH is a different story altogether.
So Jeffrey, another question from Suramashu for what to do with PNPLA3 heterogeneous mutation with F0 fibrosis?
Yes, I mean, this is the stroke of luck, isn't it? You may have PNPL3 and you have the MM gene, but still you are controlling yourself with your physical activity, your diet, etc., etc. And hence, even though genetic predisposition is there, but you are still not getting the disease because your environment, and you are, one of those people who look after your health in general ways. You can't alter your genes. You are born with them, and your MM means that your two genes are coming from your two parents, and hence if you have them, your predisposition is at a higher level if your lifestyle is also sedentary and whatnot. So you have to be careful. People don't check genes. I don't know my genes, for instance, is it MM or not? So, as we go along, we certainly would have more of these coming in as a routine test. If not, in special circumstances, we will be doing it.
Thank you very much, Professor Jeffrey. For the sake of the time, we have to move on to the next speaker. Next speaker will be Dr. Anuradha Dasanayake, consultant physician and hepatologist, Faculty of Medicine, University of Kalyania, Sri Lanka. Professor Anuradha will be speaking on the non-invasive assessment of fat who needs treatment. And may I remind you the housekeeping rule, the presentation will be 15 minutes, Q&A will be 5 minutes. Thank you very much. May I invite Professor Anuradha Dasanayake.
Good evening. First, I would like to thank our energetic president, Professor Singh, and equally energetic Secretary General, Dr. Mamun, for organizing this, and also Dr. Anil Arora for putting up the program and inviting the speakers. So I would like to talk on this because it's a topic which is very close to my heart. So I'm going to talk on non-invasive assessment of liver fat. Okay, so why do you want to assess liver fat? Because we want to identify patients who needs treatment most. So what is progressive NAFLD? It is NAFLD which progresses to cirrhosis and hepatocellular carcinoma. It involves only about 10% of patients with fatty liver. And what's the predictor of progression? Fibrosis stage is the strongest predictor of progression and liver-related mortality. What are the clinical predictors for progression and fibrosis? Age, diabetes, female sex following menopause, obesity, and as Prof. Jeffrey said, family history of NASH cirrhosis. When you need pharmacological treatment, that's only when you have progressive NAFLD. That's NAFLD with fibrosis. So how we can assess fibrosis? By two methods: invasively by liver biopsy and non-invasively various other methods like serology and imaging methods. So what we can do with non-invasive assessment methods? Can we detect the severity of fat infiltration? That's how much of fat is there in the liver. Whether we can differentiate NAFLD from NASH, the progressive form, or whether we can reliably predict advanced fibrosis. In other words, the patients who need treatment. What are the methods available for non-invasive assessment of how much of fat is there in the liver? There are imaging methods like ultrasound scan, fibroscan, the CAP score, and the MRI based methods. How useful is the ultrasound scan? Yes, it is acceptable, but it misses the diagnosis if the hepatic fat content is less than 20%, but its sensitivity is low when the patient is obese and the BMI is more than 40. What about the fibroscan CAP score? Yes, it has good sensitivity, and it can differentiate various grades of fat like mild, moderate, and severe fat. And then you have to remember these values: 248 decibels per meter, then 268 and 280 are the cutoffs, and 280 for the severe fat content, that's more than 66% of fat. But it has not been compared with the gold standard method of MRI PDFF, but at the moment, role of CAP score in NAFLD is not very well defined. This is how we do the CAP score. Here, a young patient is undergoing a fibroscan. Here, the CAP score is 204, and he is having a fairly normal liver. What about the MRI methods? MRI PDFF, that is proton density fat fraction, is the gold standard. It's very reliable and detects even lower quantities of fat like 5%. But unfortunately, it has limited availability for us, especially for us in South Asia, and it's costly and time consuming. The second question that I'm going to answer today is to see whether we can differentiate NAFLD from NASH by non-invasive methods. But unfortunately, it's still not possible for us to non-invasively predict NASH with high sensitivity and specificity, either by serological or imaging methods. But serological methods like cytokeratin 18 and imaging methods like from the invasively. Fibrosis NAFLD non-invasively. This is the $1,000,000 question that we are going to answer today. There are two methods, serological and imaging methods. Why not a liver biopsy? You know all these, why we can't offer a liver biopsy for all people. It's invasive, acceptability is low, it's painful, needs admission, carries a morbidity and a mortality and cost. And there are other issues like sampling error, and it's not practical to biopsy all. In this example, I will show you in a big piece like this, which is 30 grams, it contains only 1 in 50,000 of the liver tissue. So it's not a good sample to judge on the liver. So in this picture, I will show you that if you take the biopsy from this area of the liver, it says that 65% fibrosis. But at the same time, if you biopsy from this area, which is adjoining, it will say only that there is only 15% fibrosis. Then what are the non-invasive diagnosis methods of fibrosis, which is a rapidly evolving field? There are two serological markers which are simple and one is complex, and also imaging methods like elastography. What are the simple serological markers available? AST-ALT ratio, then the Fib4 score, and the NAFLD fibrosis index. Then there are complex patented scores which are expensive, like FibSure. Then there are imaging methods like fibroscan, MRI, and the ultrasound scan based methods. We'll take one by one. So what are the serological or biological markers available. There are non-patented and patented forms. Non-patented, the easiest is the Fib4 score, which is available as a free app online, and even the NAFLD fibrosis score is available as a free app online. So I will discuss one by one. This is the Fib4 score, came into the picture in 2006 as hepatitis C was raging. Then it is very simple, involves only age, the AST, the platelet count, and the ALT. And if it is less than 1.3, it's very reliable in excluding significant fibrosis. Here I will give you an example of how to do it in a normal looking liver enzyme, patient with normal looking liver enzymes like AST20, AST36, ALT24, but older with slightly low platelets. Here the Fib4 score is 3.39, and this shows early cirrhosis. So this is the NAFLD fibrosis score. Again, came to the picture around 2007. It involves BMI and the diabetes status in addition. Obviously, should be more reliable. And it took 13 years for guidelines to recommend to as reliable exclusion criteria to exclude significant fibrosis at primary care level. So what are the advantages of these? They are high applicability, relatively low cost, ideal for us in South Asia, and their widespread availability. What are the disadvantages of these? They are influenced by other illnesses like hemolysis, muscle disease, maybe immune thrombocytopenic purpura, and these are useful only in this age group, and age-related cutoffs are now available to get over these issues. And this is a patented test, fibro test to be precise. It involves additional features like alpha-2 macroglobulin, haptoglobulin, apolipoprotein A, bilirubin, gamma GT, age, and sex. And this is another patented serological marker, ELF score. It involves hyaluronic acid, procollagen 3, then tissue inhibitor of metalloproteinase. This I put here this because it is validated and it is being used in NICE guidelines in the UK as to exclude significant fibrosis before they undergo fibroscan. So what about the patented serological markers? Obviously, they are better because they carry much more information, but they are costly, not freely available, and they are not validated as yet. So what about the imaging techniques? They include ultrasound-based imaging techniques like FibroScan, then shear wave elastography, which involves normal ultrasound scan, and MRI-based methods, and we will take one by one. So what about the FibroScan? We have to know a lot about FibroScan because it's becoming very popular nowadays. Advantages are short procedure time, good reproducibility, and it's an outpatient procedure. Disadvantages, for us, it's a cost. We small Sri Lanka, we have only 2 scanners for the entire country. It's very costly here. And there's a 3 to 27% failure rate, and need a separate probe if the patient is very obese. And there are confounding factors like extrahepatic obstruction, acute hepatitis, congestive heart failure, and recent food intake. And this is how you do, and it's very simple, takes only a few minutes, and you get a report like this. It will tell you how much of fat is there and the liver stiffness in kilopascals. This is a normal scan. This is very significant fibrosis and cirrhosis, though their fat levels are normal. So there is a correlation between the METAVIR score on biopsy with the FibroScan. Nowadays, we take cutoff as 8 to exclude significant fibrosis and 10 to exclude cirrhosis. So shear wave elastography, the ultrasound-based method, if become validated, it's going to be easy because it can be incorporated into the normal ultrasound scan that we use. But unfortunately, It's not validated as yet, and role in NAFLD still not very clear. But if it becomes validated, this is going to be a great step forward to exclude advanced fibrosis. And MR elastography is reliable in diagnosing advanced fibrosis with low failure rates. Test the entire liver compared to biopsy, which tests only 1 in 50,000 part of the liver, and the fibroscan also, which tests only little of the liver. Response after intervention can be detected early because changes you can detect early. And this is going to be future gold standard, and it's going to be, reliability is going to be even more than the liver biopsy. So what are the controversies and concerns about non-invasive assessment of liver disease? There are quite a few. Most of these work is done in non-diabetics. So most of our patients are diabetics, and we do not know really. There are concerns whether they work equally well in diabetics. And most of the work are carried out in Caucasians, and we know our South Asian NAFLD could be different, slightly different from Caucasian NAFLD. So we really do not know whether these equally well in our patients. So this is a comparison of various guidelines on non-invasive assessments. This is EASL, this is NICE guidelines, the UK guidelines, this is Asia Pacific guidelines, this is Italian guidelines, and this is American guidelines. So all of them agree that we should go for serological tests like NAFLD fibrosis score or FIB4 score. After that, if there is significant fibrosis, we have to go for fibroscan and then for biopsy, except NICE guidelines, which recommends ELF blood test or ELF score to exclude significant fibrosis. This is algorithm developed by Loomba and others last year on how to investigate a patient with NAFLD. What it says is in the primary care setting, you have to do FOSO or NAFLD fibrosis score to exclude significant fibrosis. And if you exclude significant fibrosis, these patients can be followed up at 1 year. If you can't exclude significant, if you can't exclude significant fibrosis, in other words, the FIB4 score is more than 1.3, you have to refer them to the referral center to undergo fibroscan. Fibroscan stiffness is less than 8. That rules out significant fibrosis, and then the patient can be investigated, followed up after 1 year. If the significant fibrosis is present, then we have to consider liver biopsy and initiate suitable treatment. And if the patient has very advanced fibrosis, you have to start screening for esophageal varices and hepatocellular carcinoma. So just want to emphasize the value of non-invasive tests by this amazing data from 2 studies few years ago, which wouldn't have been possible if not for these non-invasive tests. So one is that nearly 10 to 15% of 50-year-old diabetics have advanced fibrosis by MRE by Loomba's group. In another amazing revelation, 20% of first-degree relatives of patients with NASH cirrhosis have advanced fibrosis by MRE. So soon these will be in the guidelines, because at the moment there is no clear guideline on screening high-risk patients for NASH in any of the guidelines. So, and also these have become very useful in therapeutic trials, and there are at least 10 therapeutic trials which are using non-invasive methods as their assessment of response. So to conclude, dear Chairman, ladies and gentlemen, significant progress in identifying patients who need treatment with non-invasive methods. Then CAPSCO, MRI, PDFF reliably used in the assessment of, and the quantification of liver fat. No blood test or imaging modality reliably differentiate NAFLD from NASH yet. Fib4 and NAFLD fibrosis score is best to rule out advanced fibrosis at primary care setting, and this is going to be very, very useful for us in South Asia. Transit elastography or fibroscan will select the patients for liver biopsy at tertiary referral centers, and MRI methods is the most reliable non-invasive test and is most suited for clinical trial setting at the moment. Thank you very much for your patience. Hello.
Thank you very much,
Yes.
Professor Anuradha. Your presentation draws a lot of questions. First is that if ultrasound reported as fatty liver, how should we proceed as physician? Can you hear me? Can you hear me, Professor Anuradha?
Hello, sir.
There is a question, Professor Anuradha. Can you hear me?
Yes, sir. Now I can hear you.
You can hear me?
I can hear you.
There's a question for you. If ultrasound reports as fatty liver, how should we proceed?
Hello, sir.
Can you hear me?
Yeah, yes, sir. Now I can hear you now. Yeah. Yes.
There
Go ahead
are
with the question,
questions
sir.
for you. One is,
Yeah.
if ultrasound reports fatty liver, as a physician, how should we proceed?
All right, sir. Now it's very, very simple. You do liver function tests. So if the liver functions are high, then you have to rule out all other possible liver diseases like hepatitis B, hepatitis C. And if they are, you do not diagnose any other disease, then you have to look for metabolic risk factors like diabetes, hyperlipidemia, BMI, and then start lifestyle modification. So it's a matter of excluding other liver diseases and then diagnosing metabolic risk factors like diabetes, obesity, hypertension, hyperlipidemia, and then treating them accordingly. The liver functions are abnormal, you go for go and exclude other liver diseases. And if the liver functions are within normal range, then exclude other comorbid metabolic risk factors like diabetes, hyperlipidemia, obesity, and arrange lifestyle modification and treatment.
Professor Anuradha, there's another question, which you have mentioned a series of tests. Which one is the most sensitive for the detection of early fibrosis?
Definitely MRI, magnetic resonance elastography, but unfortunately it is not available. That's the gold standard, but it's not available. For us, we can rely on fibroscan, Fib4 score or NAFLD fibrosis score, then fibroscan. And if fibroscan says there's early fibrosis, then you have to do a biopsy. That's the current guideline, and most of the guidelines agree with that.
And another, patients who are in indeterminate Fib4 or NAFLD fibrosis score range, would any other serum markers be of any help?
So at the moment, no other serum marker is validated other than Fib4 score NAFLD fibrosis score and ELF score, ELF score in the NICE guidelines. All other serological markers are not validated. So NAFLD fibrosis score, Fib4 score, and ELF, they are the ones that are validated to exclude early fibrosis.
I would choose only one last question.
Yeah.
Have any of these non-invasive methods been validated in children?
Not to my knowledge, sir. Not to my knowledge. No, no. The Fib4 is only for 35 to 65 age group.
Okay, thank you very much. We'll stop here with your presentation. Congratulations and thank you.
Thank you,
We'll
sir.
proceed to next presentation by Dr. Ananda Shrestha, my good friend, consultant hepatologist from Kathmandu, Nepal. Professor Shrestha is going to present holistic approach to intervention in fatty liver disease. Professor Shrestha, please.
Thank you, Professor Win. Thank you, Professor Win. Am I audible? Yeah. Okay, I bring greetings from Kathmandu and very good evening, ladies and gentlemen. In the next 15 minutes or so, I'll be talking about holistic approach to interventions in NAFLD. Well, I have nothing to disclose. Sorry, I can't change my slide. Where is it? Okay. I have nothing to disclose. To start with, NAFLD is a multisystemic disease. It's not only multisystemic, it is multifaceted as well. Though the primary diagnosis is NAFLD is liver-centric diagnosis. You detect NAFLD when you scan in an ultrasound, or even if you do a fibrous scan for the liver, or when you evaluate for abnormal liver function test, you detect NAFLD. But the implication of NAFLD are beyond liver diseases. You can see multiple other systems being affected, like cardiovascular disease, type 2 diabetes, mellitus, obesity, different types of malignancy, and even chronic kidney disease, which adds to the morbidity and finally leads to increased mortality in this patient with NAFLD. Now, over the last couple of decades, the incidence and prevalence of NAFLD has almost doubled. And at the moment, you can see that nearly about 25 to 30% of the world's population are affected by NAFLD. And what worries us the most is NAFLD is the most rapidly rising etiology for end-stage liver disease leading to a transplant. And the same story continues for the liver cancer as well. And it has been extrapolated that in another couple of decades, it is going to be the topmost leading cause of end-stage liver disease and liver cancer, surpassing almost all the rest of the etiology. Now, this paper on natural history by Leonard Adams' group in 2005 totally changed the paradigm of NAFLD and totally changed the way we look at the NAFLD today. They followed a population of NAFLD in Minnesota, Olmsted County, over the period of 16 years. And what they found was the survival of these patients of NAFLD were lower than the reference population. That means these people would die more frequently than the reference population. And when they looked into the cause of death in these people, they found that the topmost cause of death in these people were ischemic heart disease or malignancy. And liver disease contributed only to the 13%. That is the third top leading cause of death. So even though the disease is primarily a liver disease, it's primarily a liver diagnosis, but then people with NAFLD would die because of ischemic heart disease and malignancy more frequently. So that's the reason why we should look NAFLD in much more holistic approach and not just dwell into the investigations in a liver-centric approach. This is another very interesting study that was a retrospective cohort study done in Europe, United States, and Asian countries, which included about 619 biopsy-proven patients, which were followed for duration of about 12.6 years. And they found that about nearly 1/3 of these patients died in this period. And you can see that the most important cause of death here is a cardiovascular death that accounted for about 38.3% of the total deaths. And second was extrahepatic cancers, which is then followed by liver cirrhosis and its complication that accounted for just 10%. So it's very clear that even though the disease is liver-centric disease, the people who eventually die because of more frequently because of ischemic heart disease or malignancy. Now let's look into the cardiovascular outcomes in NAFLD patient. Now this is one of our own data, and conventionally we know that NAFLD is associated with multiple conventional metabolic risk factors like impaired fasting glucose, waist circumference, hypertension, and dyslipidemia. And at any point of time, nearly about 3/4 of these patients of NAFLD will have 3 or more metabolic risk factors, giving the diagnosis of metabolic syndrome. And if you see, these metabolic risk factors would interact in many ways, leading to hyperinsulinemia, diabetes, atherogenic, and Professor Jeffrey, and finally culminate into cardiovascular disease, which could be ischemic heart disease, which could be alternative heart disease, or sometimes arrhythmogenic heart disease as well. And there has been a long-standing relation between NAFLD and surrogates of cardiovascular disease. And you can see that there was one very interesting systematic review of meta-analysis that published showed that associated with the carotid atherosclerosis as evidenced by increased carotid intima media thickness. There's another very beautiful study among 10,000 participants when they did a CT scan of cardiac CT scan, and they found that these patients of fatty liver had independent association with high coronary artery calcium score more than 0, which was independent of insulin resistance or other features of metabolic syndrome. So how these data translate into real life practices? Patients of fatty liver are at increased risk of cardiovascular event, may be fatal or non-fatal. So this meta-analysis showed that NAFLD patients were more susceptible to have cardiac events. And this was even much more stronger linked when the patients had a severe form of fatty liver, that is NASH without fibrosis. So ladies and gentlemen, when somebody comes across your outpatient department with a definitely, and there are other things beyond the liver that we have to emphasize, and severity risk is one of them. So one of the ways of approaching severity risk is following a simple severity risk assessment, and you can add carotid intima media thickness in your practice, and it should be very liberal while using statins and antiplatelet therapy when appropriate. And I just want to make a point out here that many physicians, hepatologists think that statins are unsafe in cirrhotic patients or patients with liver disease, unless the patient is decompensated liver cirrhosis. Second, extrahepatic malignancy. That's a beautiful study that was published and had whatever thousands who were followed with 7.5 for years. That NAFLD, and during this period, they found that these patients of NAFLD were more prone to develop hepatocellular carcinoma. Look at the hazard ratios was 16.73 in males colorectal cancers and females breast cancer. Thus, this relation was even much more strong in patients who had significant fibrosis, as evidenced by high NFS score and FIB-4 scores. There has always been, the obesity has always been linked with different types of cancer. So there was one school of thought that is NAFLD independently associated with malignancies, or is it because of obesity, NAFLD people are having more cancer? Because obesity is fairly common in NAFLD patients. To answer this question, this beautiful study was conducted, and this study, they included about 4,722 NAFLD subjects who were both lean as well as obese. And they had matched controls, about 14,000 of them. They were matched for age, sex, and BMI. And these patients were followed for about 21 years. And they found that the NAFLD patients had increased risk of cancer, which was independent of occurrence of obesity. Now here, in this first study, you can see this is the healthy controls. The black dots are the patients who didn't have NAFLD. And the blue dots are the patients who had NAFLD. So NAFLD patients clearly had increased incidence of different types of cancers, and this was independent of obesity. So NAFLD may actually be a factor of obesity cancer relationship or association. Now, colorectal adenoma and carcinoma have been very closely studied with NAFLD and has been very closely tied with. And in this meta-analysis, they've shown that the chances of having colorectal adenoma in NAFLD patients is higher than the control. And this gives a spark of thought in my mind that provocation of thought that should NAFLD patients be screened for colorectal adenomas or carcinomas way beyond and way before the age cut of 50, as it is recommended in the standard guidelines. Another group of patients, another group of malignancies is hepatocellular carcinoma, which is fairly common in patient who has got NASH cirrhosis. But whether NAFLD who are pre-cirrhotic or NASH, just NASH patients before stage of cirrhosis, are they prone to develop liver cancer? How common is it, and how should they be screened during pre-cirrhotic stage? This question still remains to be answered. But then I found a very beautiful meta-analysis out which showed that people who have got NASH clearly had increased incidence of hepatocellular carcinoma as compared to those people who did not. However, the incidence of hepatocellular carcinoma in pre-cirrhotic NAFLD or NASH patients is very variable and certainly doesn't cross the screening threshold of about 1.5% per year, which is required for any etiology to undergo hepatocellular carcinoma screening. So at the moment, what can be recommended is these patients who have pre-cirrhotic NASH should not be screened for hepatocellular carcinoma. However, if somebody has NASH-related liver cirrhosis, they should be screened as per standard guidelines. Now, hepatological aspect has been dealt in by my previous speakers, focusing on the fibrosis and its importance. NAFLD and NASH, plain NAFLD and NASH both have increased liver-specific mortality when it comes to liver-specific mortality. And then the most important point out here is the fibrosis. At any point of time, 20% of the patient will have significant fibrosis at any point of time. And in general population, if you see across different studies, you'll find that cirrhosis is found nearly about 4% of the NAFLD patients. Now, this is again a very beautiful study that again highlights the importance of fibrosis. Those patients who had fibrosis had fairly lower survival as compared to those patients who did not have fibrosis, irrespective of other histological features, including NASH or inflammation. So what everything boils down to is patient with NAFLD, only predictor of long-term outcome is fibrosis. So it does have a prognostic value. And while evaluating pharmacological interventions or while evaluating the efficacy of any drugs, fibrosis becomes the one of the main milestone or the main landmark to the drug is really going to help in long term or not. Now, the key to management, as I said earlier, in NAFLD should not be liver-centric. It should improve overall survival. And this should cause reduction of cardiovascular risk, reduction of liver-related risk, address obesity, address dyslipidemia, and overall metabolic risk factors. Now, lifestyle modification has been the main crux and will probably remain as the mainstay of therapy in management of NAFLD. There have been very few FDA-approved drugs for use in NAFLD that are pioglitazone and vitamin E, and there are very lucrative other drugs that are in trials and are very exciting, with very exciting results. But I think that these newer drugs will never be able to compete with the lifestyle modification, at least in terms of the benefit that they offer in a holistic view. And why these drugs will not be very, very much effective as compared to lifestyle modification is most of the drugs are liver-centric. They would at the most look at the endpoints, histological endpoints like improvement in resolution of NASH or regression of fibrosis. There are no data on these endpoints, and they don't really look for other concomitant outcomes like cardiovascular outcomes, dyslipidemia, or and obesity. And data on fibrosis regression with these drugs are very sparse. There are a few drugs that have shown fibrosis does regress with these drugs, but then they are very sparse. And I would like to remind you again, fibrosis is the main histological landmark, or the only landmark that probably tells you what's going to happen to that patient, not only with hepatic as well, but also extrahepatic outcomes. So weight loss is again the mainstay of the main corner, one of the pillar of lifestyle modification. And weight loss is particularly very important because only weight loss has shown to be effective in reduction of a reduction or regression of fibrosis. And weight loss can be achieved by a combination of diet, exercise, or alone themselves. Now, this is a very beautiful study that showed that 52 weeks lifestyle intervention achieved weight loss in people. And this weight loss was associated with resolution of NASH, regression of fibrosis, and status improvement. And much more profound at higher degrees of weight loss. Those patients who lost about more than 7% of their baseline body weight had a higher degree of fibrosis regression and other histological parameters. Unfortunately, the only problem with this with this data is most of the patients were not able to lose weight. Like 70% probably could weight less than 5%, but the rest of the 30% probably they weren't able to lose weight as much. And second thing is, once these patients are taken off this intervention, they rapidly tend to have a rebound weight gain. Now, dietary intervention is another cornerstone for lifestyle modification. There are multiple different types of diet, but I've just classified into two broad headings. The first one is hypercaloric diet, which aims at cutting down about 500 to 1,000 kilocalorie below the daily requirement. So basic idea is to get a negative deficit in calories, expecting that this is going to help lose weight and also decrease liver fat. It is done so by cutting out simple carbs, fructose and glucose, and introducing complex carbohydrates. Another approach here is isocaloric diet with altered macronutrient composition. Here, the total calorie remains the same and is much more easier to follow, but then the composition is altered. Total calories. But one thing is for sure, as long as they are not as long as they are not hypercaloric, as long as they don't contain simple sugars,
I think Dr. Anantan's internet is a little bit slow.
We cannot hear Dr. Shrestha's presentation.
Yeah, he has been disconnected.
He is already at the end of his presentation. Shall I wind up?
He is here. Dr.
Hello?
Anantan is here.
He's back.
Yeah.
He's back.
Yeah, did I miss the major? Yeah, did I miss the major part? I mean, how long did I miss? I mean, hello?
Yeah.
There was some problem with the net, so my apologies. Okay, should I continue my talk?
Yeah.
Okay, fine. So, okay, I don't know if you missed my previous slides. I'm not very sure about that, but I'm going to continue from right on where I am now.
Yeah.
The dietary interventions in NAFLD are basically, divided into basically two groups. One is hypocaloric diet, which contains of 500 and 1,000 kilocalorie diet deficits. This helps in cutting down simple carbohydrates and fructose and glucose and introducing complex carbohydrates. Another approach is doing an isocaloric diet with altered macronutrients. Mediterranean diet has stood the test of time. It contains high monounsaturated fatty acid and is beneficial in reducing liver fat. Another very rapidly rising, very getting popular kind of thing is ketogenic diet, which has got very high fat levels and low carbs. And there are other different types of diet where high protein diets are introduced. There are no head-to-head trials comparing different types of diets, but one thing is for sure that if a diet does not contain simple sugar, are not hypercaloric, and doesn't contain saturated fat, they are probably going to do good in your liver. Another interesting approach that is gaining momentum these days is intermittent fasting, especially in social media. You can see lots of advertisement with intermittent fasting on Facebook as well. I found this randomized control trial where they used modified intermittent fasting technique when they did alternate day intermittent fasting. And what they found was it helped in reducing weight. It helped in biochemical remission. It also helped improve in decreasing, the liver stiffness. And these were very easier to adhere than the conventional, very stringent type of diet. So overall, at the moment, what we know is dietary interventions in NAFLD helps to reduce hepatic fat and improve cardiovascular outcome. And this is independent of weight loss. Even if you don't lose weight, there'll be reduction of hepatic fat. There'll be improvement in cardiovascular outcome. But again, there will be no direct impact on fibrosis. But fibrosis tends to improve if there is concomitant weight loss. If you can combine dietary modality along with exercise and achieve a weight loss, this is really going to help you in reducing or regression of fibrosis. Physical activity is another third pillar of lifestyle modification. And I would like to summarize, exercise alone may reduce hepatic fat, just like cardio. And you need weight loss. So for all the two modalities, both dietary as well as physical activity, you really need weight loss if you really want to have fibrosis regression. So the recommendations that patients with NAFLD or CVD should have at least 6 minutes of exercise, that is about vigorous activity, about 75 minutes per week, or somebody, if they can't have a vigorous type of activity, at least moderate intensity activity, just like cycling or steady running for about 150 minutes per week does good. But always vigorous type of activity during short span is better than moderate intensity activity over 150 minutes. And again, there are two types of exercises, aerobic and resistance exercises. Both are equally good. Aerobic focuses on intensity, good for reducing CVD risk. Resistance helps you to reduce weight and has got added advantage of afterburner effect. So NASH-related cirrhosis needs a special mention out here. People with cirrhosis are very much susceptible to sarcopenia. They're frail. Protein supplementation about 1.2 to 2 gram per kg body weight is needed. Calorie reduction should not be very stringent in this group of patients. Small frequent meals and late night snack really helps in improvement of sarcopenia or prevention of sarcopenia. And even there are data that it reduces blood pressure. This is my second last slide. And regarding exercise, the target for exercise in NASH-related cirrhosis should be maintaining good performance stats rather than losing weight. They should avoid sarcopenia. And there are evidences that home-based supervised exercise programs are not only beneficial, but they're also safe. They have got a beneficial role in improving lean muscle mass, preventing sarcopenia, and also reduction of water pressure. So ladies and gentlemen, to conclude my talk, NAFLD is one of the commonest liver diseases affecting nearly a third across the continent. It is estimated to top the list as an etiology of ESLD and SCC in days to come. However, CVD and malignancy are the two most other common cause or competing cause of death in these patients with NAFLD. And evaluation of NAFLD should always integrate CVD risk management, metabolic risk management, obesity, and dyslipidemia, along with the standard protocol for evaluation of a liver. Lifestyle modification and weight loss is the key to global reduction in morbidities, given that there are very limited options for the pharmacological therapy at the moment. And to tackle the NAFLD epidemic or pandemic, I would say, community intervention targeting mass population is the only way to tackle. Thank you very much. If there are any questions, I will be happy to answer.
Thank you very much, Professor Srisra. I fully agree with your last sentence. The only way to tackle this epidemic is targeting the community and the mass approach. Because whatever we say, that exercise, these individual programs will not be very effective. For your question, there are a few questions, but I allow only 2 questions. One is the one question that I allow is the interrupted fasting. It is how effective is in weight reduction?
Well, intermittent fasting has just gained momentum these days. I was able to find just a couple of papers, and one of them was randomized clinical trial. Well, this was conducted in a very small group of patients, nearly about 30 patients, and they were just intervened for about 8 weeks, as compared to 52-year weeks long trial that I've shown you earlier. So initial results are good, and physiologically also, intermittent fasting should be good because it helps to restore the normal autophagy process that has been lost in NAFLD. So physiologically also, it seems quite good. And one thing, while going through this paper, what I found was in Southeast Asia, maybe, the Muslims, maybe in Hindus or in Buddhists, there's a very good tradition of having a fasting. So, I just quoted this thing that those approaches were far more scientific approaches, like looking at the data, the things that are coming up, and the evidence that fasting promotes autophagy and restoration of autophagy that helps to combat NAFLD. So I really look forward to newer data in days to come, and I think should have a good result.
Thank you very much, Dr. Srisra. Because of the time factor, we have to move on to to the next presentation. That's the limitations of current pharmacotherapy and the way forward by Professor Kaushal Madam. He's a director and head gastroenterology and hepatology, Max Smart Super Specialty Hospital, New Delhi, India. And Dr. Madam is the Secretary General of the INASAL, Indian National Association for the Study of Liver. Dr. Kaushal Madam, please.
Dr. Kaushal Madan, please unmute yourself.
Sorry about this. So, good evening, everyone, and thanks to Dr. Kinmawin for the kind introduction, and thanks to Dr. Singh and Dr. Mamun for inviting me or making me part of this SASL convention. And I think there was some confusion about the title of the talk. The title which was there in the flyer says pharmacotherapy for NAFLD and the way forward. So I'll talk about this. You must be wondering why we are talking about pharmacotherapy in the end, and you've heard all the previous speakers tell you about the multi-system involvement which you have in this disease called NAFLD. The most common causes of death also in patients who have NASH is cardiovascular disease and extrahepatic cancers rather than liver disease per se. It is supposed to be the third most common cause of mortality in these patients. So that's why we come to liver-specific pharmacotherapy in the end. And lifestyle modification, you just heard Dr. Anand Shrestha tell you, does appear to be the best and most durable treatment for NAFLD, but unfortunately, most are unable to follow this form of therapy. So if you look at this paired liver biopsy study among NASH patients who underwent lifestyle management, and on the right side, you have those who had achieved resolution of steatohepatitis. If you look at their median weight loss, it was more than 7%. So, and those who had a median weight loss of less than 3%, there was no resolution of steatohepatitis. The same slide which Dr. Shrestha also present, that as the amount of weight loss increased, so did the proportion of patients who had a regression of fibrosis. So weight loss also leads to regression of fibrosis, fibrosis being the main driver of end-stage liver disease in these patients. But unfortunately, in this particular study itself, only 30% of the patients were able to achieve at least 75% patients are not able to follow these lifestyle interventions. For them, possibly you need pharmacotherapy. If you look at the pathogenesis of NAFLD, people have already spoken about this. It starts with the first hit, that is liver fat. Then it progresses through the stage of necroinflammation and reaches to liver fibrosis, which goes on to progress to cirrhosis or liver cancer. Or in some cases, liver fat may directly go on, pure fatty livers may go on to develop liver fibrosis. And this is driven by these second hits, or if you want to call them multiple hits of oxidative stress, inflammatory mediators, cytokines, and apoptosis, modified by nuclear receptors like PPAR and farnesoid X receptors at various stages. So if you look at this pathogenesis, you can see that you can now target the pathogenesis, the pathophysiology of non-alcoholic fatty liver disease at various points. The first hit, the multiple second hits, the nuclear receptors, and the stage of progression from necroinflammation to liver fibrosis. And now we have in our armamentarium a multitude of drugs which are able to target at these various levels, and in future we are going to get more. So let's look at vitamin E, which targets the oxidative stress. You are all aware of this study, the PIVANS trial, the phase 3 trial of 247 adult non-diabetic NASH patients who received either placebo or vitamin E or pioglitazone. And if you look at the ALT improvement in patients who received vitamin E and pioglitazone, it started as early as 1 month, became maximum at around 6 months and then persisted throughout the course of therapy with vitamin E and pioglitazone. When the vitamin E therapy was discontinued, the ALT level bounced back to the baseline, suggesting that it was not durable. The moment you stop therapy, you reach back. Another important thing to see is that the baseline of ALT levels during the therapy hovered somewhere around between 40 and 50. And these, we all know that this is not the real baseline which the patient should have once they improve their liver disease. It should be lower than this. So that means vitamin E helps, brings down the LFT, but possibly we need more than this. Further, it also improves histology. In this particular study, as compared to placebo, more number of patients had an histological improvement in NASH, those who were given vitamin E. And even in the tonic trial, which was done in the pediatric population, 58% achieved histological resolution of NASH as compared to placebo. But importantly, vitamin E has no effect on fibrosis. This study looked at and correlated the histological response with the ALT response and showed that the NAS score did correlate with ALT responders. Those who had an improvement in ALT, their NAS score improved significantly as compared to those who were non-responders in terms of ALT. But when they looked at fibrosis, there was no difference. Whether ALT came down or did not come down, the fibrosis did not improve. So this is one of the limitations of vitamin E. Although it improves histology, improves ALT, does not improve fibrosis. In the previous lecture, you heard fibrosis is the most important driver. So you have to target fibrosis. However, we had this recent study published last year, although it was a retrospective study of long-term vitamin E, in which vitamin E 800 units per day was given to 90 patients compared with propensity matched controls which were not given vitamin E, and followed up for a median of 5.6 years, which is quite a significant duration. Almost 70% of these also had cirrhosis and 2/3 also had diabetes. So the previous studies were done in non-cirrhotic NASH patients, non-cirrhotic, non-diabetic NASH. So these patients, most of them had cirrhosis and diabetes. And what they demonstrated that patients who were receiving vitamin E had a significant lower risk of hepatic decompensation. Their transplant-free survival was significantly better as compared to those who were controls. It did not matter whether they were diabetic or non-diabetic. You had similar good responses in diabetic patients as well. And surprisingly, the all-cause mortality was also significantly lower in the group which received vitamin E. This is in contrast to a large meta-analysis of vitamin E, which had earlier demonstrated that vitamin E increases all-cause mortality and had raised a question mark on the safety of vitamin E. However, there are still the issues of vitamin E causing hemorrhagic strokes or causing prostate cancer, albeit at a very lower rate. But they must be kept in mind while you are treating your patients of NASH over a long duration with vitamin E. The second target, so mind you, I am only talking about the drugs which are available in the market for regular use. I am not talking about drugs which would be coming in next 1 to 2 years. I am talking about the drugs which are available and we can use. Targeting the liver fat, the PPAR agonist. So this drug, saroglitazar, possibly the only approved drug in any country. So this has been approved in India. It is a novel dual PPAR alpha and gamma agonist, which not only reduces hepatic steatosis and hepatic inflammation, it has a multitude of effects on the necroinflammation and has a direct effect on reducing liver fibrosis. But let's see what happens when you use it clinically. So this was a recent phase 2 randomized control trial called Evidences 4 among 106 patients, published, presented in AASLD 2019, which showed that 4 milligram of saroglitazar, there was a significant reduction in ALT levels and a significant reduction in liver fat as determined by MRI PDFF. And more importantly, if you look at more than 30% reduction in liver fat, almost 40% patients were able to achieve this in the group which were receiving 4 milligram, which which is a very significant amount because it has been shown that patients who do reduce their liver fat by 30% have better clinical outcomes and lower risk of progression. So almost 40% of patients were able to reduce liver fat by more than 30%. Now, this is another uncontrolled study of 44 patients, which looked at non-invasive method of looking at fat and demonstrated that after 6 months of use of saroglitazar, there was a significant reduction in the CAP values. And recently, this was a Indian study, the phase 3 randomized control trial published, done in India, presented recently in APDW 2020 of 102 patients of biopsy-proven NASH, 52 weeks of saroglitazar. The primary endpoint they looked at was 2-point reduction in NASH score without worsening of fibrosis, and patients who were receiving saroglitazar had a significantly better primary outcome as compared to those who were receiving placebo. It was almost double, and there were clinically meaningful responses in ALT and lipid profile once these patients were given saroglitazar. But again, there was no mention of reduction in fibrosis. So phase 3 RCT has happened. The results have been presented in a big conference, but no mention of reduction of fibrosis, suggesting that possibly there's something to read in between the lines. So, like I told you, both these drugs have not, although they are available, they are good in reducing fat, reducing inflammation, reducing ALT, but possibly they do not have an effect on liver fibrosis. But we need to have longer follow-up before we are confidently able to say that. So now we have this new molecule which targets liver fibrosis called obeticholic acid. But before I talk about this, the disclaimer is that this drug has not been FDA approved for use in NASH. It has been approved for use in primary biliary cirrhosis. So this was based on this phase 3 trial called the Regenerate trial, which looked at placebo, OCA 10 milligram and OCA 25 milligram. The target of inclusion was more than 2,400 patients. The interim analysis was done at 18 months, which was actually presented in this Regenerate trial, which was published recently. The primary endpoint they looked at was fibrosis reduction by at least one stage with no worsening of fibrosis, or NASH, no worsening of NASH, or NASH resolution with no worsening of fibrosis. And they demonstrated for the first time, possibly any drug which has demonstrated this in a phase 3 trial, that significantly more number of patients who received 25 milligram dose of OCA had fibrosis improvement by more than one stage. Even the 10 milligram dose had a significant result. And although the absolute value may be 13%, but 13% of patients who had advanced fibrosis shows a fibrosis improvement of more than 2 stages, which again is significant, although the absolute number is small, like I just told you. And add to that, when you looked at patients who had worsening of fibrosis, this gap looks even more wider between placebo and obeticholic acid 25 milligrams. So less number of patients in the higher dose had worsening of fibrosis, more number of patients in the placebo had worsening of fibrosis. So if you look at this difference between placebo and obeticholic acid 25 milligram, this is quite significant. And not only fibrosis, it did have effect on outcomes which patients are interested in clinic. Is my ALT coming down? Is my GGT coming down? Yes, it comes down in a dose-dependent manner. Higher doses leads to higher reduction of ALT as well as GGT. The problems with OCA are it causes pruritus in almost 50% of patients in the higher dose group. It also causes a rise in LDL, which may be problematic. I'll just talk about. So pruritus is dose dependent. Almost more than 50% of patients will develop pruritus, and they will develop pruritus sooner as compared to those who receive placebo or who receive lower doses of OCA. The second issue is LDL increase, which again is dose dependent. And the problem with LDL increase is many of these patients have metabolic syndrome. They already have dyslipidemia. So to give them a drug which can cause a rise in LDL may become counterproductive. But what was significant is by the time the patient completed 18 months of treatment, the LDL had already almost come back to the baseline level, or the difference was very small. And those patients who did have a significant rise in LDL, it could be easily controlled by starting them on statins. So I'll talk something about anti-diabetics which are available in the market and have an effect on patients with non-alcoholic fatty liver disease. The first molecule is SGLT2 inhibitors, which leads to renal loss of glucose, glycosuria. The control of hyperglycemia leads to reduced fatty acid synthesis. The improvement in insulin sensitivity also leads to reduction in fatty acid synthesis by inhibiting the de novo lipogenesis. So there are two small randomized control trials. This one is from Japan, which used dapagliflozin. 57 patients of diabetes with NAFLD given 5 milligram dapagliflozin over 24 weeks versus placebo. And they looked at the FibroScan CAP and LSM value, which improved significantly. Both the values improved in the group which was given dapagliflozin. And this is a study of empagliflozin from India. Again, 50 patients, type 2 diabetes with NAFLD. The tool they used was MRI PDFF, 10 milligram empagliflozin versus control for 20 weeks. 100% of these patients were also receiving metformin, and 70% were also receiving DPP-4 inhibitors in both the groups. And in the EMPA group, there was a significant reduction in fat after the end of 6 months. And not only that, there was a significant reduction in BMI, ALT levels, hemoglobin A1C, and triglyceride levels. The second anti-diabetic molecule I want to talk about is the GLP-1 agonist, liraglutide, which is secreted from the L cells of small intestine. And in NAFLD, they lead to increased beta oxidation of fatty acids and improved insulin sensitivity. This was the initial phase 2 trial of liraglutide, the LEAN study. 52 NASH patients over 48 weeks of liraglutide injection daily versus placebo. And you can see that almost 40% of patients who received liraglutide had a resolution of NASH without worsening of fibrosis as compared to placebo. So you must be wondering why I talked about PPARs, I did not talk about pioglitazone, because as hepatologists, I think most of us either fear or have stopped using pioglitazone, although there are cardiovascular side effects also in higher doses, but the issue of weight gain, because all of us have been encouraging our patients to lose weight in order to improve their NASH. But you give a drug which leads to a 3 to 4 kg weight gain instead of weight loss, it becomes counterintuitive. So what is the way forward? That was the next part of the talk. So way forward can be in 3 ways. So one is selective targeting. So before we talk about these targets, again, it is important to emphasize that lifestyle measures have to be given in all patients in the form of diet and exercise. This cannot be overemphasized. This has to be told to the patients that whatever drug we may want to give you, whatever drug you may be taking, but the backbone of treatment is going to be lifestyle measures. So selective targeting, I told you that you may have multiple targets, and now you have multiple drugs which you can use to target these areas. So if you may have a patient of NAFLD who has increased fibrosis, who have increased ALT, but no fibrosis. You had a lecture just before this talking to you about how you should non-invasively measure liver fibrosis by using FIB-4 or NASH fibrosis score or FibroScan. So you have high ALT but no fibrosis. The options can be saroglitazar or vitamin E. Both have been shown to reduce ALT rapidly in these patients as early as 1 month. And these patients are happy that their ALT is coming down. And you are happy because there is no fibrosis. You know that once the ALT settles, possibly further inflammation will settle down, and patients will be relieved that they came for a high ALT and that is settling down. You may have a second scenario where you have NAFLD with increased ALT and more than F2 fibrosis. Here you have an option of obeticholic acid or vitamin E or saroglitazole. Why I'm saying that along with OCA, you have this option, because again, remember that OCA has not been approved for use in non-alcoholic fatty liver disease. As and when it gets approval, this may be where you can place it. Or you may have NAFLD along with diabetes and dyslipidemia, raised ALT, no fibrosis. Here, along with this option, you can also give them the option of SGLT2 inhibitors or GLP-1 analogs. But remember, many of us as hepatologists are not very confident in using anti-diabetic drugs in our patients of non-alcoholic steatohepatitis. We want to take a opinion from our endocrinologist colleagues. But and one of the fear we have is the fear of inducing hypoglycemia. So please remember that these drugs, the SGLT2 inhibitors and GLP-1 analogs, do not produce hypoglycemia. They usually are euglycemic drugs. So this was selective targeting. The other option can be sequential additive targeting. You start with one drug and add another drug. So for example, NAFLD, increased ALT, no fibrosis. You start with either saroglitazole or vitamin E. If there is no response, you add the other drug. So selective additive targeting. And the third important way is multi-targeting or combination therapy. And I think the future is going to be of multi-targeting therapy or combination therapy in patients with NASH. So you may have NAFLD with increased ALT, no fibrosis. You can combine saroglitazole and vitamin E because both act at a different level in the pathogenesis. You have NAFLD, increased ALT, and you have advanced fibrosis. You can consider combining OCA with saroglitazole or OCA with vitamin E. Vitamin E is safe, has been shown to be safe, can easily be combined with this. Second, these two drugs can be complementary. OCA leads to a rise in LDL. Saroglitazole leads to a reduction in LDL level along with a reduction in triglyceride. So the side effect of raised LDL can be counteracted by co-prescribing saroglitazole in such patients. And finally, you may have NAFLD, diabetes with dyslipidemia, increased ALT. You can have either saroglitazole or vitamin E and combine them with SGLT2 inhibitors or GLP-1 analogs. So to summarize, ladies and gentlemen, lifestyle modifications is possibly the only durable therapy in patients with NASH, but is difficult to follow and endure, but still should be emphasized to the patient that this is the backbone of treatment for your condition. Now, many targets are available for pharmacological intervention in NASH or NAFLD, and we have at least 2, 3, or 5 molecules which we can use to target these different areas. So available therapies I just told you now are vitamin E, saroglitazole, obeticholic acid, and anti-diabetic drugs. And the way forward appears to be either selective targeting or sequential additive targeting or multi-targeting. And in future, I think the multi-targeting approach is going to be the approach of future for managing NASH. Thank you for your patience here.
Thank you very much, Dr. Kaushal, Madam. You have very clearly presented the benefits and the pitfalls of the pharmacological therapy. And you have many questions, but I have chosen, I will choose only one question for you. Some of the questions you have already answered in your presentation. The one question that I want to have chosen is vitamin E and pioglitazone. Should they be given only after the liver biopsy, or are you going to prescribe without the liver biopsy?
Yeah, I think that's a very important practical question. When these drugs got recommended by AASLD, since the the phase 3 trial was done in patients who were biopsy-proven NASH. So the mandate was to only use these drugs in patients in whom you have a biopsy-proven NASH and not pure fatty liver. But subsequently, we have also realized, and people have also started using non-invasive markers of fibrosis. So patients who have raised ALT, patients who have multiple metabolic risk factors or multiple parts of metabolic syndrome, and who on non-invasive markers have advanced fibrosis, you can presume them to have advanced NASH or patients with fibrosis. So you can start these drugs without doing a liver biopsy in them. I am not saying that I am recommending not to do a biopsy, but we all know, I think everyone in this panel knows that we are not able to do biopsy in 99% patients who have NAFLD. So we have to have a way to treat these patients without doing a biopsy.
Thank you very much, Dr. Kaushal Madan. And I would like to close the webinar academic session here. And thank you all the speakers. Thank you, my co-moderator, and thank you, the chairman, Professor S.P. Singh. I would like to hand over the floor to Professor Mamoon and the Professor Singh for the closing remarks and for ending the webinar. Thank you all.
Thank you very much, Professor Kim Wang Win. We have really enjoyed the session. The lectures are highly good learning for us. I'm sure the audience will be highly benefited. Just before I hand over the mic, floor to the President of SASL, there's one announcement. These webinars will be held regularly from now onwards. The next SASL webinar will be held on the 4th Saturday of September, which is September 26th, same time. I will circulate the topic and the faculty in due course. Now it's my pleasure to invite Professor S.P. Singh, President of South Asian Association for the Study of the Liver, to give his closing remarks and conclude the session for the day. Thank you very much.
Good evening, all those who are listening to our webinar, and also to all the participants who spoke. We have had a wonderful beginning to this series of webinars which we are going to have, and I must thank Mamoon Al-Matab, our dynamic Secretary General, for the wonderful job he has done and the initiative he has taken. Next, I would like to thank COVID-19, which is responsible for, or which has enabled us to use this platform. This platform was always there for education and for our meetings. And thanks to COVID-19, that we have started using this platform, virtual platform, and we are going to have many more meetings than we would normally would have had. And the beginning was made with NAFLD, which has assumed, as already has been said, pandemic proportions. And we had a lovely talk beginning from pathogenesis by Wasim Jafri. And then Anuradha spoke of how you can assess fat and how to use the different tests which are there, available non-invasive tests, because as has already been spoken by Kaushal Madan, hardly anyone does liver biopsy these days, excepting for people like me. We do a lot of liver biopsy, but yes, there are a lot of difficulties. Ananta made a wonderful lecture on holistic approach, because NAFLD is not just a liver disease. It's a lifestyle, it's a way of living which gives you this disease. You may have the genes, but if your lifestyle is good, you will not have any problems. And all the genes which we talk of, actually it modifies all the liver diseases. It is not that these genes are specific for NAFLD. If you have them, you are predisposed. If you have NAFLD, then you have more of fat, you have more of disease. At the same time, you have an advantage if you have this gene. If you exercise and if you modify your lifestyle, you are likely to improve. You are likely to, I mean, the changes are going to take place much more easier than in one who doesn't have the genes. And lastly, we had Kaushal Madan, who gave you, it was more like a crystal gazing, that if you have this, I mean, they are wonderful, but probably both in the field of the assessment, non-invasive assessment, we have not had any validation from this part of the world. We have looked at it in a small way in my department, and we were not happy with NFS and so, right? But we need to look, and I think Sadal can, all those who are interested in NAFLD, especially the Sadal people who are here, who are speaking, we could, look at whether these methods work for our population or not. The algorithm is useful for us or not. And lastly, the same thing regarding management. What percentage of people really need all those new molecules which are coming up or are lined up? A very small minority, not only in our country, but also in the West. Significant fibrosis is only there in around 7%, whether you look at the Americans or the British or our population. So all these newer drugs are meant for a very small percentage of the population. We need to work more in the field of prevention, education, not only of our patients, but also of the physicians, general practitioners who are going to see most of these cases, how they must handle them, how they can prevent them, and when they should refer to us. I mean, that is very important. So I thank all the speakers, and in addition, Professor Khin, who done a wonderful job moderating the whole session. I also thank Mamoon once again for a wonderful job he has done. I think he's the right man to be the Secretary General, and he's going to take Sadal into really, top gear. Thank you.
Thank you, Prof.
Thank you, sir. Thank you, sir.
Thank you, sir.
Bye.
Bye.
Thank you.
Bye-bye.
You are watching Raj TV.